Hello everyone, good morning everybody. So welcome to Sri CPD National CPD Provider Webinars. So it's today lecture number 211 for 2025. And I will give you some housekeeping tips before we start. So always keep your mics muted please, and also the videos off, and this lecture will be recorded throughout. So the webinar link will be available from 9 a.m. to 9:50 a.m. to join in, and all late attendees will be entertained thereafter. And each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And the CPD points are strictly adhered to national CPD guidelines. So thank you for the strict adherence of the CPD regulations and your kind compliance. So this is improved and maintain the standards of the CPD program. So let me introduce you our few tips about the questions. So questions time is at the end of the webinars, and if you have a question, please type it in the chat function. And please change your chat settings to all panelists and attendees so that these questions can be answered. And if you have a very specific question, you can email us to office3@gmail.com. So let me introduce to our today's topic. So nutrition in renal disease is our topic, and our distinguished lecturer is Dr. Manoji Gamage, consultant nutrition physician, nutrition division, National Institute of Nephrology, Dialysis and Transplant, Castle Street Hospital for Women. So over to you, Dr. Manoji Gamage.
Good morning to all of you. I'm Dr. Manoji Gamage, consultant nutrition physician, and today I'm going to talk to you regarding nutrition in renal diseases. So we all know that in the nephrology units that they take a great effort to look after the kidney patients. So nutrition is the kidney care that goes the extra mile. So with nutrition, you could make the quality of life of the chronic kidney disease or kidney disease patient a better place with this extra mile of nutrition. So though we talk about kidney diseases, in general I'll be concentrating on chronic kidney diseases because it is the one that goes on for the longest time in life. So, and the duration is long in this disease. So therefore, the nutrition implications are similarly quite long. So, in my outline, so I'll be talking about metabolic changes in chronic kidney disease and these changes, how they relate to cause in malnutrition, and also how to assess the nutritional status of a patient with chronic kidney disease, and then what are the requirements and the diets available for a patient with chronic kidney disease, and also what is the role of parenteral and enteral nutrition. So moving on, so what we call chronic kidney disease is the abnormality of either the structure or function of a kidney that lasts long for more than 3 months and it also has implications on health. So this can be classified according to the cause of the renal failure and the GFR or the glomerular filtration rate and the amount of albuminuria. So you would see, so depending when the glomerular filtration rate decreases, the severity increases obviously, and also even in the higher stages of glomerular filtration rate, if you have a higher albuminuria, that disease is in moderate severity. So moving on, so what are the metabolic changes in chronic kidney diseases that we should know to understand the importance of nutrition in kidney disease? So this graph shows, this has been charted, there is the glomerular filtration rate in the x-axis, and in the y-axis you will find the prevalence, and they have charted the complications with the kidney functions. So the main complications that we commonly know with chronic kidney disease, the hyperthyroidism, anemia, acidosis, hyperkalemia and hypophosphatemia has been taken into consideration in this study. And you can see as the glomerular filtration rate decreases, these complications do increase. And also when the GFR is less than 30, they are more pronounced. So the metabolic effects of this kind of hyperthyroidism, anemia, acidosis, hyperkalemia and hyperphosphatemia. So all increases with the severity when the glomerular filtration rate decreases. But also don't forget to see the initial stages. So even with a relatively high glomerular filtration rate, if you are leading towards chronic kidney disease, these metabolic derangements have started to occur in your body. So therefore, these patients, even at an early stage of restricted glomerular function, will be having the metabolic changes and leading to protein catabolism. So that puts them in increased vulnerability for nutrition. So what is the components to further elaborate on this? So we know when the kidney fails, there is uremic toxemia that accumulates within the kidney. So that itself, the toxins, uremic toxins, and if there is inadequate dialysis, which is common in resource limited settings like our country. So these toxins accumulate in the body, forming an inflammatory atmosphere within the body. So the systemic inflammation rises, interleukin starts rising. So they in return causes reduced appetite by certain appetite suppressing hormone release such as leptin. So there will be appetite suppression, so decreased nutrition intake therefore. However, the body catabolizes because the metabolic rate is increased. So therefore, altogether there is a vicious cycle which leads to protein energy wasting in chronic kidney disease. So this is again to highlight what happens. So there will be these uremic toxemia, inflammation together causing malnutrition and also leading to cachexia and protein energy wasting, and all these factors that I talked to you before are going to influence on this aspect, the infections that they might have, the volume overload that they have. So all comes together into reduced overall intake, absorption and utilization. So that will result in weight loss, low BMI, loss of muscle mass, in children growth failure and also cardiovascular complications. So an increased hospitalization and ultimately reduced quality of life. So this is a nice demonstration again to highlight the same things. So it is a vicious cycle, the cause effect vicious cycle between chronic kidney disease and protein energy malnutrition and its complications. So you would see as the glomerular filtration rate decreases, the malnutrition increases, and it can range from 28% even up to 75% of people being affected. So so it's a vicious cycle. So why are we talking about this protein energy malnutrition? So what is the implication? So this is another study where they have looked into the 90-day survival and 1-year survival of patients with end-stage kidney disease on dialysis. So when they have protein energy wasting, which is the one with the straight line is when you don't have protein energy wasting, and the intermittent line is where you have protein energy wasting. So you would see it's the length of life, so 90-day survival drops drastically when there is protein energy wasting when compared to when there is no protein energy wasting. So therefore, it's important for us to prevent this and support them nutritionally. So then to do that, we have to know where the patient is. So a good nutrition assessment is needed. So we have to do what is called nutrition screening. So this could be done by even a medical person, but doesn't need to be a nutritionally trained individual. So this is a quite simple tool, which is renal NUT tool. This is screening tool. So you would see what they gather here is the weight and the BMI. So they would calculate the body mass index in this, and some cardinal questions as to whether there is an unintentional weight loss or whether there is already low BMI, and whether they have they are already on nutrition supplementations, and whether their food intake is reduced, and so and what is about their appetite. So this screening tool will allow you to get a assessment of the patient's risk. So if it is more than 2 or more, then this patient needs referral to a nutrition prescription. So it's a very simple tool that can be used at OPD settings and in renal specific units. So whenever there is admission, that you would know to find the patients who are at increased risk of protein energy wasting. So it's important to highlight that BMI alone is not a good indicator with chronic kidney disease, obviously because of volume overload. So the weight, the flares will be fluid overload, so the weight is not a good marker. And also you might find a person coming to your clinics who is already in the normal BMI. But if you do ask him this questionnaire, you will realize that he might have had a weight loss actually. Even though he is still in the normal BMI, it might be that he has lost weight. And sometimes it might be the early stages where you have not seen the weight drop, but you can catch it with the loss of appetite and loss of the reduced intake. So therefore, it's important to know all these aspects to get a good idea about the nutritional assessment. So when there is nutrition screening, that is the initial stages, initial first step that you can do, and then when they come, then you could refer them to a medical nutrition unit in your hospital or in your units. So then there will be a detailed assessment with a nutrition with nutrition specialized interventions. So it would be a comprehensive assessment when you refer to nutrition units. So not only anthropometry, biochemistry, as well as clinical and history, the physical examination, which is nutritionally focused, and also a dietary recall. So all these would be taken in together with a comprehensive assessment. So that is absolutely needed to get a good overlook of the patients. Otherwise you might miss certain individuals. So this is another quite popular assessment tool, which is a comprehensive tool. It's a 7-point subjective global assessment. So this also takes into considerations the weight loss, the food intake, the loss of appetite, and the muscle mass, activity level, GI function. So all together, and they give a cumulative score. So these also can be used for nutrition assessment when you are referred to a nutrition specialized unit. So this is again to show another table, but it also summarizes the things that we use for the nutrition assessment. So, so when it comes to biochemistry, the protein assessment, albumin, and also anemia, so all these biochemical aspects will also taken into consideration. So once you find these things from the nutrition screening and then assessment, you can use this table to see whether there is protein energy wasting in the patient who you have examined. So this is the criteriation for the protein energy wasting syndrome diagnosis from the International Society for Renal Nutrition and Metabolism. So they have considered serum chemistry, body mass, muscle mass, and also dietary intake, a comprehensive thing. So there are 4 categories. If at least 3 categories, 1 point from 3 categories is present, then you can consider the patient is at protein energy wasting syndrome. So the chemistry includes serum albumin, which we often do in the wards if it is less than 38 grams per liter, and also the transthyretin, the prealbumin, which we do not do commonly, and also cholesterol if it is less than 100. So that is the chemistry. So body mass, if the body mass is less than 18.5, and if there is unintentional weight loss of more than 5% for over 3 months or 10% over 6 months, and if the total body fat is less than 10%. And also the muscle mass, if the muscle loss is more than 5% over the 3 months or 10% over the 6 months. So that can be taken with muscle area calculations. So you can find this internationally actually muscle area charts where they have showed the muscle areas, that is that is usual for the normal population. So when the patient muscle area is calculated, measured and then put into these kind of graphs, if it deviates more than 10% from the average, that is the 50th percentile, then we can consider that there is a loss of muscle mass. And also dietary intake, even just by asking the patient if their spontaneous intake has reduced to less than 25 kilocalories per kg for the last 2 months, and also if the spontaneous protein intake is less than 0.8, which you can take from a 24-hour dietary recall. So these categories are there. So at least if one is positive in 3 of the categories, you can consider that the patient is protein energy wasted. And also not to forget sarcopenia in these patients. So there can be sarcopenia coexisting with protein energy wasting. So there are 2 entities that can coexist in patients with chronic kidney disease. So, but they have common diagnostic criterion, but there are 2 entities. Sometimes you might find a patient who is not so protein energy wasted, the BMI is normal or maybe sometimes overweight, but they might have sarcopenia. So the identification and assessment of sarcopenia separately is also important in patients with chronic kidney disease because it has a prognostic value with the muscle mass. So of course you can use the SARC-F clinical questionnaire and this assessment, and if it is positive then move on to muscle strength assessment with things like hand grip dynamometer. It's a bedside test that you can use where you clench your fist with the machine and then you can measure the strength of the hand muscles. So if that is low, then you can diagnose, you can say probable sarcopenia, and it is confirmed with imaging. So and then when you find that, you can grade the severity with doing physical performance tests like the gait speed, so on. So by doing this is the usual sarcopenia assessment. So this is important to be done in patients with renal failure. So other common things other than wasting and sarcopenia, the other common nutrition issues in CKD includes hyperkalemia that we commonly see, and hyperphosphatemia, acidosis, anemia and poor diabetic control. So all of these are key nutrition issues that interrelate together and has effects on each other, causing overall deterioration of the nutritional status. So what are the nutritional requirements in chronic kidney disease? So we have this KDOQI guidelines, Kidney Disease Outcome Quality Initiative. It's an international organization that deals with kidney health. So according to them, which is the 2020 guidelines from them, so the energy requirement is about 25 to 35 kilocalories per kg. So in a normal population, we would say 25 to 30 kilocalories per kg. So you would see it's a little bit higher, taking into consideration the catabolic state of the patient with chronic kidney disease. And also this graph I actually added to this slide is to explain what happens with protein to the glomerulus. So when you have proteins in your afferent arterioles, they actually they dilate the afferent arterioles and constrict the efferent arterioles, so causing an increased intraglomerular pressure. So that will cause further damage, and glomerular filtration and proteinuria will be increased when there is high protein intakes. So therefore, in chronic kidney disease where there is already glomerular damage, if you are a non-diabetic patient, then the protein content is recommended to be low, as to at 0.5 to 0.6 gram per kg per day, or you can even further reduce this for the patient by using keto acids. So those keto acids are amino acids when the ammonia component of the amino acid is removed. So we all know it's the ammonia component of the amino acid or the protein that causes increasing of urea in the body and nitrogen waste. So once it is not there in the preparation, it can be used more effectively for protein synthesis without the risk of accumulation of nitrogen waste. So therefore, if keto analogues are used, now even in Sri Lanka we can find keto analogues. So if these keto analogues, they come in preparations as capsules. So if you can use these, you can reduce the protein intake even to lower levels as 0.3 to 0.4 gram per kg per day to preserve the kidney functions, the glomerular function, preventing further damage to it. But of course, if it's a diabetic patient, protein is needed for the good control of glycemia also. Therefore, this guideline recommends a little bit higher amount than if you are non-diabetic, that is 0.6 to 0.8 gram per kg per day. So sodium, again we have up to 5 grams salts per day, and you can further reduce it depending on the clinical circumstances. So potassium, it is important to highlight that potassium, there is no universal restriction. So what people usually do is when you have chronic kidney disease and then they are quickly restricted out of all the greens and all the vegetables. So it need not be like that. So potassium should be restricted only to maintain its adequate potassium levels. So if there is no potassium levels are normal, actually you need not restrict potassium levels from the very early beginnings. And phosphorate also, you have to have adequate amount of phosphate to maintain normal phosphate levels. And also dietary pattern, this guideline talks about the plant-based Mediterranean type of diet, which I will talk to you in my next few slides as well. So yes, Mediterranean is a healthy diet style which is based on more natural food than the artificial food. So that kind of diet is promoted from these guidelines for overall kidney health. And usually fluid restriction not needed for pre-dialysis patients, but depending on your clinical guidance, that can be adjusted for the patient. And so this is the other important international organization, the KDIGO, Kidney Diets Improvement Global Outcome is this guideline, KidGO guidelines. Now they have a more latest guideline on 2024. So the similarities, they are both similar, they are a lot similar when you consider both KDOKI and KidGO guidelines on with regards to nutrition requirements. And it's important to say that they have emphasized when talking about potassium that actually restricting the potassium, the processed food which are very high in potassium and phosphates, and these phosphates which are inorganic phosphates, they are very bioavailable. So they can be very detrimental to the patients with kidney disease. So therefore, when actually if you are restricting these kind of synthetic potassium is more important than cutting down on the fruits and vegetables for all stages. So what about if they are on dialysis? So if they are end-stage kidney disease patients on chronic dialysis, so what are the changes? So we all know when there is dialysis, there is a clearance of the blood and there is a dialysate. So there is loss of proteins and water soluble vitamins also into this the circulation. So there is a loss of it. So therefore, the requirement when they are on dialysis is more when it comes to dietary proteins. So there is about 1 to 1.2 grams per kg body weight you can prescribe for patients on maintenance hemodialysis. So those people again who have diabetes especially, it's important that you maintain the protein intake, because protein in diabetes help them to control their glycemic control as well. So energy requirement, of course, it's the same, so 25 to 35 kilocalories per kg, just as for the other patients with chronic kidney disease. So moving on for the hospitalized patients. So when once they are hospitalized, if they are without any acute kidney disease, you can start with the low protein intake, and if they are actually on conservative management, so 0.6 to 0.8 gram per kg body weight. And if they are with CKD and also kidney failure, and they have been started on renal replacement of some sort, like the kidney replacement therapy, dialysis, then because of the loss and the demand is high, so you have to give higher amounts of proteins. That's about 1.5 1.2 grams per kg per body weight. And also if there is again, if you have AKI, that acute kidney injury on top of chronic kidney injury, then the requirement increases. So therefore, rather than the 0.6 to 0.8 that I spoke at the first sentence, when there is an AKI, it has been increased to 0.8 to 1 gram per kg per day. So when there is an AKI, actually the requirement for protein increases. So if they are acutely ill also with the AKI or CKD, AKI on CKD, and there is acute critical illness also, their requirement increases. So therefore you can start with 1 gram per kg body weight and then even move on to 1.3 gram per kg per body weight if tolerated. And if they are on renal replacement such as CRRT, then the losses are higher and you can even go up to 1.7 gram per kg per day. So you would see that you start at a lower level and then change according to the requirement and the stage of critical illness inside the hospital. So what we have to remember is this protein restriction has to be very subjective in disease, in chronic kidney disease, depending on their clinical status as well as whether they are critically ill or whether they are having an AKI. So if they have an AKI, their protein requirement increases. So little bit about the requirement in pediatrics. So pediatric renal disease patients are really special because they are not only patients and they are also children. So they are having special demands, special requirements because they are growing. So the energy requirement in the early stages, initial prescription of energy intake of children with chronic kidney disease stage 2 to 5, they approximately their requirements are as the same of the normal other children of their age. But if you find that their weight faltering, then of course you have to adjust their energy intakes to the upper levels to keep them to gain weight and to prevent them from going into severe malnutrition. And of course also now in the recent years you might even come across children who are overweight and obese with chronic kidney disease. Then actually you have to encourage them to have a appropriate weight. So you can adjust the energy intake even at that point to get the appropriate weight gain without compromising oral nutrition. So overall well-being of the child, though they are CKD or not, will remain the same. Your interest in treating a child overall remains the same. So protein requirements is very important, unlike in adults which I spoke before. So we go on to very low levels of protein like 0.6 to 0.8 grams if they are on conventional treatment, but in children we do not go like that. We do give their RDA. So they should be kept at the recommended daily allowance to promote optimal growth in these children even though they are having kidney failure. So at least the minimum safe level, depending on their the uremic status, the kidney dysfunction, at least the minimum safe level has to be maintained in children, and we do not recommend low protein intakes for children. And when they are on dialysis, their needs are even higher, as I explained in the adults as well. So therefore, because they lose more in the dialysate, and this has to be supplemented or given more in their diets. So if they do present with persisting high blood urea levels, because as their children we cannot sometimes limit their food intakes at homes, and they might come with high urea levels, and then we might be able to sometime tweak their intakes to reduce these blood urea levels. Otherwise, generally the proteins should be given adequately to optimize their growth as children. So we spoke about proteins in adults and children with chronic kidney disease. So what are the types of proteins? So there is talk about animal proteins and plant proteins. So some people say there is new evidence from the Kedoki also, as I said, whether plant proteins and the plant-based diet and Mediterranean diet is beneficial for CKD patients, but there is still no clear evidence. However, the KIDIGO 2024, the international guidelines for kidney disease, suggest to advise people with CKD to adopt healthy and diverse diet with a high consumption of plant-based food compared to animal food and a lower consumption of ultra-processed foods. So therefore, it is overall, when you are in early stages of kidney disease, it is more that you go for a balanced, well-balanced natural diet and keep away from processed food which have very high bioavailable potassium and phosphate as well. So, what about, I'll talk about each individual electrolyte, because electrolyte balance becomes important in CKD because kidney has a main function in titrating the electrolytes. So what about sodium? So the recommendation is that they suggest that the sodium intake remains less than 2 grams of sodium per day, or that is less than 5 grams of sodium chloride per day, which is just like for the general population if you take general advice for patients with chronic kidney disease. So you have to avoid food items that are high in salt. That doesn't mean that it should be a no salt level for patients with CKD, because we obviously know with the things that we spoke before that appetite is very much suppressed in chronic kidney disease. Therefore, unnecessary restrictions can actually be very bad for the patients, leading to further reduction in food intake. Therefore, what we have to avoid is the items that are especially high in salt rather than the natural salt intakes. So these are the high items like the sauces, the things like processed meat, bacon, dry fish, salted nuts. So these things, these kind of tinned food, so the cubes and fermented fish, so these kind of food items are actually high in sodium. So these high in, especially ones that are high in sodium, should be avoided in kidney disease and is discouraged. So also it's important to avoid adding salt, salty seasons at the table. So some not commonly in Sri Lanka, but in the other parts of the world we see that people do add salt to their diets on table. So that should be discouraged in patients with chronic kidney disease, and especially these artificial food items, processed and ultra processed food, they do have high amount of salt. So these should be avoided, and the patient should be advised and educated about the traffic light guidelines in choosing the appropriate food items which should be low salt items, and of course try their best to avoid ultra processed food as much as possible. So for the things like the dry fish, boiling them in large amounts of water and then washing them off and soaking before they are cooking. So these can be done to minimize the amount of salt in the food. And also processed meat should be avoided, and the fresh fruits are better than always frozen or canned food items which have high amount of salt as preservatives. And also eating from home is very important when you want to manage the electrolytes of a kidney patient, because then you would know what you add to your meal rather than not knowing what is in it. And also this is a other suggestion that we would suggest with the low appetite already in CKD patients. We could use other substances, other condiments to make the food tastier with a low salt intake. So moving on to potassium. So it is not a complete universal restriction for potassium in patients with chronic kidney disease. It all depends on the level of potassium that you have in your body. So you should not tell to all your patients to stop all the potassium or the vegetables and fruits that they are taking just because they are patients with CKD. So it should be done when it is needed, and actually because potassium rich food items are the greens and the vegetables unnecessary restrictions will actually not benefit the patient, and that will be detrimental to their overall health. So it's an individual choice. Rather than telling to stop the greens, the naturals, you should always concentrate on avoiding processed food which have high bioavailable potassiums, and processed food items again. And this is one thing that you can do at home and advise patients to do at home to reduce the potassium in their food items. So that is called leach in a way, where you peel and cut the vegetable into small pieces, then wash them, and then with drinking water, and then you soak it in a large water pot overnight and change the water several times. And then when you cook also, you cook in a large amount of water and then rinse them also thoroughly before you make actual your preparation of food. So this is leach in a way the potassium. So this can be used by patients with chronic kidney disease who need potassium restrictions, so that they can eat little amounts of vegetables or the high potassium food items by leaching them. So it's important as medical professionals to have a list of things. It's handy to have this kind of a list. This colorful one is from our unit from the National Kidney Institute Maligavatta. So if you have a list of food items which are high in potassium, moderate in potassium and low in potassium. So if it is the high in potassium, if it is more than 200 milligrams of potassium in 100 grams of food, if it is high, that is considered high. So if it is between 100 to 200 milligrams in 100 grams of food, that is moderate, and if it is less than 100, you could take it as low potassium. So if you have this kind of a list, you can give to your patients and advise them to avoid the high potassium food items, and the portions has to be advised on, because even a low potassium variety, if they eat a lot of it, can cause high potassium intake. So it's important to give this and advise them that they could take low potassium one or two per day, and then moderate maybe one per day, and the high potassium ones you should take rarely, and then other moderate and minimum potassium ones should be not taken on such days when that is needed. So moving on to phosphorus. So normal serum levels of phosphorus can be maintained by having a normal phosphate intake of 800 to 1000 milligrams per day. So the phosphorus restriction, of course, we start rather early to prevent further glomerular damage. You have to take phosphate intake, because it's important to mention the phosphate comes from protein sources, especially animal protein sources, which are also essential to the body. So therefore you have to restrict it to the amount that you have to restrict. That is not a complete restriction, but portion control, and get guidance from a nutritional professional, a person from the medical nutrition units in the hospital. Those the staff can guide you with the phosphorus intake. So the phosphate high food items, so of course dairy, nuts, dried food, seeds, whole grain, meat and protein items, processed meat are very high in phosphates. So again, to have a chart like this, and to avoid in processed food, I once again stress they are high bioavailable. So that might be the first step in controlling the diets. So you do those restrictions, and moving on to nutrition supplementations, the importance of oral nutrition supplementations. So in these guidelines, the KDIGO guidelines, so when there is protein energy malnutrition, or when there is minimum intake and at risk of malnutrition, so oral nutrition supplements which are specialized nutrition compositions, the formulas can be used to improve the nutritional status if dietary counseling alone and dietary prescription does not help. So there is evidence to show its benefits. And also, if that is failing, if the oral nutrition supplementation fails, you can even move to enteral nutrition with tube feed in the nasogastric, nasojejunal tubes, and this has to be done quite early and quite promptly, especially in children. So in my experience, I've seen patients who are waiting renal transplant, especially these children. So they are also growing, but there are a lot of inhibitors to food intake in them, and so they go on to malnutrition. So it's important in these children to be proactive and to start on enteral feeds, NG feeds in very early stages if they cannot achieve the nutrition requirements from oral intake with counseling and all the support and oral nutrition supplements. So the parents actually have a great stigmata against having the nasogastric tube in our country. So they should be counseled and given the knowledge that this how beneficial it might be if you actually can gain the very good growth potential in the children. So therefore these steps are very proactive and should be encouraged, and the parents and the caretakers mind should be made from the very beginning so that they are ready for it when the time comes. So parenteral nutrition also can be handy, and it is useful when oral nutrition supplements, the counseling, enteral nutrition, everything fails. You can also use parenteral nutrition. So one important parenteral nutrition supplementation in kidney disease patients is the intradiabetic parenteral nutrition supplementation. So it's a new modality. So what they do is that intradiabetic parenteral nutrition is a specific form of nutrition supplementation for end-stage kidney disease patients on hemodialysis. So they are based on the administration of nutrients, so usually all in one bags in the extracorporeal circulation circuit during each dialysis session. So when they dialyze in the venous arm, you can give these the total parenteral nutrition in all in one bags or as in components to run with the same duration of the dialysis. So by doing this onto every dialysis session for about 3 months, they have shown that you can achieve good results in patients who are correctly chosen for this. So you have to have a parenteral nutrition pump. It's mandatory if you are using this kind of parenteral preparations. So what are the criteria? So everybody is not suitable for this and everybody should not be given this. So if there's spontaneous intake, less than 50% nutrition targets are being achieved, and there you try all your best to improve it with counseling and oral nutrition and intranutrition, but still not happening, and the patient is severe at risk of malnutrition, then and also they have these kind of indications who meet 3 or more of the following, that is their albumin is low, their BMI is low, the subjective global assessment score which I showed you is low, unintentional weight loss is also there. So when all of them come to play together, then there is an indication for intradiabetic parenteral nutrition, and that also can be used to enhance the nutritional status of patients with chronic kidney disease. So I have brought you through the important factors about nutrition in chronic kidney disease, starting from the point the reasons for malnutrition, and then what is the malnutrition we find in chronic kidney disease and how to diagnose it, and what are the energy and protein requirements, and how to advise patients on their electrolyte balances, and advanced nutrition therapy on enteral nutrition and as well as intradiabetic parenteral nutrition. So in summary, I would like to highlight these factors. So chronic renal failure affects body's nutritional stores absolutely. So energy and protein loss is significant and leads to negative outcomes in patients, especially when they are on dialysis. So you have to anticipate and identify, an early referral can make a positive impact in this patient's quality of life, pre-transplant as well as post-transplant. So if the patient walks into a transplant in a very good nutritional state, the patient will recover early and will return to normal life quite early, and the complications post-operatively will also be minimum. So therefore, it's a profit when it comes to healthcare, also in the pace of patient care. So dietary restrictions should be made very cautiously. It's a very individualized thing, and there is no uniform restrictions. It depends on the cause of the disease, the stage of the disease, as well as the level of malnutrition. So low protein diet, low sodium intake with adequate energy intake, and predominantly natural plant-based diets can reduce CKD progression and uremic symptoms. Medical nutrition interventions are crucial for the long-term well-being of patients with chronic kidney disease. So I would like to wind up my presentation. Thank you very much for patient listening.
So thank you very much, Dr. Manoji Gamage, for joining our pre-CPD program. So our sincere thanks goes to Dr. Manoji Gamage, Consultant Nutrition Physician, Nutrition Division, National Institute of Nephrology, Dialysis and Transplantation, Castle Street Hospital for Women, for excellent lecture and the time and the presentations. So thank you so much, and you can find the link in the chat box, and kindly give your feedbacks, answer the post-assessment questions, and also receive your e-certificate for the participation. So I am very sorry to inform you that our madam will not be able to participate in the Q&A session today. So we will send the answers to your questions via email. So thank you so much for everyone for joining today, and kindly find the link in the chat box. So give your feedbacks and also answer the post-assessment questions to receive your e-certificate. Okay, thank you so much and have a nice day.